Welcome to StudyNeuro. In this session, we will explore the principles of cranioplasty, one of the most important reconstructive procedures in modern neurosurgery. We will discuss when cranioplasty is indicated, how the timing of surgery influences recovery, and how careful planning can improve both neurological and cosmetic outcomes. Evidence guides every decision. By the end of this presentation, you will understand the goals of cranioplasty, recognize the key principles of patient selection, and compare the advantages and limitations of autologous bone with modern synthetic implants. We will also review the basic operative techniques, examine common complications and their management, and highlight the evidence that supports current clinical practice. Before we begin, join the StudyNeuro community across YouTube, Facebook, TikTok, Instagram, and X for high-yield neuroscience education, neurosurgical updates, and practical clinical pearls. If you find this video helpful, please like, share, subscribe, and let us begin. Cranioplasty is the surgical reconstruction of a defect in the skull using either the patient's own bone or a synthetic implant to restore the normal shape and function of the cranium. Its purpose extends well beyond cosmetic repair because it protects the underlying brain, helps restore normal cerebral physiology, and can support neurological recovery after severe brain injury. This procedure continues to evolve. Cranioplasty is also one of the oldest reconstructive operations in neurosurgery, yet it remains an active area of innovation, with advances in biomaterials, computer-assisted design, and three-dimensional printing, making reconstruction more precise, more personalized, and often more durable than ever before. The history of cranioplasty spans thousands of years and reflects the remarkable evolution of surgical reconstruction. Early civilizations attempted to repair skull defects using materials such as gold, silver, and even natural gourds, demonstrating an early understanding of the need to protect the brain. Innovation has always driven progress. During the 19th century, surgeons increasingly adopted autologous bone grafting because of its biological compatibility, while the 20th century saw the development of synthetic implants that offered new reconstructive options. Today, patient-specific implants designed with advanced imaging, computer-assisted design, and modern manufacturing techniques allow highly accurate reconstruction with improved cosmetic and functional outcomes. A cranial defect is an area of missing skull bone that leaves the brain inadequately protected and may alter normal cranial function. These defects most commonly develop after decompressivecraniectomy, traumatic skull injury, or the surgical removal of a cranial tumor, although they may also result from bone infection, congenital abnormalities, or failure of a previous cranioplasty. The underlying cause matters. Identifying the reason for the cranial defect is essential because it influences the timing of reconstruction, the choice of implant material, and the overall surgical strategy, all of which contribute to achieving safe reconstruction and the best possible neurological and cosmetic outcomes. Cranioplasty restores the normal contour of the skull, but its benefits extend much further by helping re-establish normal brain physiology after a cranial defect. Studies have shown improvements in cerebral blood flow, cerebrospinal fluid circulation, intracranial pressure regulation, cerebral metabolism, and venous drainage following successful reconstruction. These physiological changes are clinically important. In some patients, these improvements can reverse the syndrome of the trephinade, a condition in which the cranial defect disrupts normal brain function and contributes to neurological decline. As normal cranial mechanics are restored, patients may experience meaningful gains in neurological function and rehabilitation potential. Cranioplasty is performed when reconstruction of a cranial defect is expected to provide meaningful clinical benefit. Common indications include large skull defects after craniectomy or trauma, restoration of cerebral protection, and improvement of cranial appearance following bone loss. These are important goals. The procedure should also be considered in patients who develop neurological deterioration after decompressive craniectomy, particularly those with syndrome of the trephined or sinking skin flap syndrome, because restoration of the skull can improve brain physiology and neurological function. Persistent cranial defects that require definitive reconstruction are another well-established indication for cranioplasty. Cranioplasty should only be performed when the patient is medically stable and the surgical field is suitable for reconstruction. Certain conditions increase the risk of complications and may require the procedure to be delayed, including active infection, untreated scalp necrosis, poor soft tissue coverage, uncontrolled intracranial hypertension, hemodynamic instability, or severe systemic illness. Patient safety comes first. Careful assessment before surgery allows these problems to be identified and managed, reducing the risk of wound breakdown, implant failure, and postoperative infection, while improving the chances of a successful and durable reconstruction.
Selecting the right patient for cranioplasty requires a thorough clinical assessment before surgery is planned. The patient's neurological status should be carefully evaluated, including whether there is improving limb weakness or persistent cognitive impairment. Medical conditions such as poorly controlled diabetes or severe heart disease should also be considered, while the scalp must have healthy soft tissue without wound breakdown or infection. These details are important. Other factors also influence the decision. Imaging should confirm that cerebral swelling has resolved and that there is no active infection or untreated hydrocephalus. Considering all of these findings together helps identify patients who are most likely to benefit from cranioplasty while minimizing the risk of complications.
The timing of cranioplasty is an important part of surgical planning, but there is no single schedule that suits every patient. Current international consensus describes 4 practical timeframes: ultra-early within 6 weeks, early from 6 weeks to 3 months, intermediate between 3 and 6 months, and delayed beyond 6 months after decompressive craniectomy. These categories provide a useful framework. The decision should always be individualized. Factors such as resolution of cerebral swelling, absence of infection, wound healing, overall medical stability, and progress in rehabilitation are often more important than the number of weeks since surgery. Careful clinical judgment remains the key to selecting the most appropriate time for reconstruction. Several clinical factors influence when cranioplasty should be performed, and each patient should be assessed individually before surgery is planned. Active infection, hydrocephalus, poor wound healing, ongoing brain swelling, medical instability, progress in rehabilitation, and the possible need for cerebrospinal fluid shunting all affect the timing of reconstruction. Every factor deserves careful attention. For example, cranioplasty is usually postponed until an infection has been treated, the scalp has healed adequately, and cerebral edema has resolved. Likewise, a patient who requires a ventriculoperitoneal shunt or remains medically unstable may benefit from further optimization before reconstruction. Careful assessment of these factors helps reduce complications and improves the chances of a successful surgical outcome. Cranioplasty materials are broadly classified into 2 major groups, autologous and alloplastic. Autologous reconstruction uses the patient's own bone, most commonly a preserved bone flap that was removed during decompressive craniectomy, although a split calvareal graft may also be used in selected cases. Native bone remains an important option. Alloplastic reconstruction uses synthetic implants designed to replace the missing skull. Common examples include titanium, polymethylmethacrylate, polyetherethacrylate, hydroxyapatite, and newer composite implants, each offering different mechanical properties, biological behavior, and cosmetic characteristics. The choice of material depends on factors such as defect size, patient age, previous infection, cost, and the goals of reconstruction. Autologous bone uses the patient's own skull for reconstruction, making it one of the most biologically compatible materials available for cranioplasty. It offers excellent tissue integration, is relatively inexpensive, and avoids introducing a foreign implant. These are important advantages.
However, autologous bone also has important limitations. The bone flap must be preserved until reconstruction, and over time it may undergo bone resorption, particularly in younger patients. Infection can also compromise the graft, and in some cases, the original bone flap may not be available because it was damaged, contaminated, or discarded after the initial surgery. Careful patient selection is therefore essential when choosing this reconstructive option. Synthetic implants provide an alternative when the patient's own bone is unavailable or unsuitable for reconstruction. Materials such as titanium, polymethylmacrylate, and polyether ether ketone do not undergo bone resorption, can be manufactured to match the patient's anatomy precisely, and are readily available for a wide range of cranial defects. These features make them attractive options. Despite these advantages, synthetic implants also have limitations. They are generally more expensive than autologous bone, and wound breakdown can lead to implant exposure, sometimes requiring removal. In addition, although many materials have shown excellent clinical results, long-term outcome data remain limited for some of the newer implant designs. Careful material selection should therefore be tailored to each patient's clinical needs. Modern technology has changed how cranial implants are planned and produced. Computer-aided design and computer-aided manufacturing allow surgeons to plan the reconstruction digitally and create implants that closely match the patient's individual skull defect. Greater precision is now possible. Three-dimensional printing can further support the production of customized implants, while virtual surgical planning allows the reconstruction to be assessed before entering the operating room. Together, these technologies have made patient-specific implants more practical, particularly for complex cranial defects where accurate restoration of the skull contour is important. Successful cranioplasty begins with careful preoperative planning to ensure that both the patient and the surgical field are ready for reconstruction. This evaluation includes thin-slice computed tomography with three-dimensional reconstruction to accurately define the cranial defect, assessment of scalp vascularity to confirm adequate soft tissue coverage, selection of the most appropriate implant, screening for active infection, and routine laboratory investigations. Preparation is critical. Each of these assessments contributes to surgical decision-making. For example, three-dimensional imaging helps design patient-specific implants, while infection screening and laboratory results identify problems that should be corrected before surgery. Thorough planning reduces complications and improves both functional and cosmetic outcomes. Cranioplasty follows a systematic surgical approach designed to achieve safe reconstruction while minimizing complications. The previous scalp incision is usually reopened. The scalp flap is carefully elevated, and adhesions between the soft tissues and dura are meticulously dissected before the dura is inspected for integrity. Precision is essential. Once the operative field has been prepared, the implant is positioned to restore the cranial contour and secured with rigid fixation to ensure stability. Careful hemostasis is then achieved, followed by a tension-free layered wound closure that promotes healing and reduces the risk of cerebrospinal fluid leakage, wound breakdown, and postoperative infection. Although cranioplasty is generally considered a straightforward procedure, several intraoperative challenges can make reconstruction technically demanding. Surgeons may encounter dense adhesions between the scalp, temporalis muscle, dura, and underlying brain, while temporalis muscle atrophy can make tissue dissection and anatomical restoration more difficult. Careful technique is essential. Other challenges include dural tears, venous bleeding, cortical injury, cerebrospinal fluid leakage, and inaccurate implant positioning. These complications can prolong the operation and increase postoperative morbidity, making meticulous surgical planning, gentle tissue handling, and precise implant placement critical for achieving a safe and successful reconstruction. Postoperative care is an essential part of successful cranioplasty because it supports recovery and helps detect complications at an early stage. Patients require close neurological observation, careful wound assessment, postoperative imaging when appropriate,
ongoing infection surveillance, effective pain control, and timely rehabilitation to optimize functional recovery. Close monitoring matters. Management should also be tailored to the individual patient. For example, rehabilitation should begin as soon as the patient's condition allows, while seizure treatment is provided when clinically indicated or continued in patients with an established risk. Regular follow-up helps confirm proper wound healing, stable implant position, and continued neurological improvement. Cranioplasty is generally beneficial, but it carries a meaningful risk of post-operative complications that require careful surveillance and prompt management. Important complications include infection, hemorrhage, hydrocephalus, seizures, bone flap resorption, implant exposure, cerebrospinal fluid leakage, and wound dehiscence. Early recognition is critical. Reported overall complication rates range from about 15 to 35%, although the exact rate varies with patient characteristics, implant material, surgical technique, and the definitions used in different studies. Careful patient selection, meticulous operative technique, and structured post-operative follow-up remain the most effective strategies for reducing these risks and improving long-term outcomes. Preventing complications begins long before the operation and continues throughout the patient's recovery. Success depends on careful patient selection, choosing the right time for reconstruction, meticulous surgical technique, strict aseptic practice, secure scalp closure, appropriate implant selection, and close post-operative monitoring. Prevention starts with planning. Each step plays an important role in reducing risk. For example, delaying surgery until infection has resolved, selecting the most suitable implant for the clinical situation, and ensuring careful wound closure can lower the chances of wound breakdown and implant failure. Regular follow-up also allows complications to be detected early when they are often easier to manage. Future developments in cranioplasty are moving beyond simply replacing a missing section of bone toward implants that can actively support biological repair. Researchers are investigating bioactive materials and tissue-engineered bone that may encourage new bone formation and integration with the surrounding skull. This is the next step. Smart biomaterials and customized regenerative scaffolds may allow implants to respond more effectively to the local tissue environment, while artificial intelligence could assist with implant design and surgical planning. Advanced three-dimensional bioprinting may also enable more complex biological structures to be produced, with future research focused on combining mechanical strength, precise anatomical reconstruction, and true biological integration. In summary, cranioplasty is much more than replacing a missing piece of skull. It restores the protective barrier around the brain, helps normalize cerebral physiology, supports neurological recovery, and improves cranial appearance. These benefits are greatest when the procedure is performed in carefully selected patients at the right stage of recovery, using meticulous surgical technique and an implant that matches the patient's clinical needs. Every decision matters. Modern cranial reconstruction continues to evolve. Autologous bone remains an important option because of its excellent biological compatibility, while advances in synthetic biomaterials and patient-specific implants now provide surgeons with greater flexibility for complex cranial defects. Equally important is the early recognition and prevention of complications, since long-term success depends as much on careful follow-up as it does on the operation itself. Good planning makes the difference. Thank you for watching. If you found this presentation helpful, join the StudyNeuro community for more high-yield neuroscience education and clinical pearls. You can find us on our social media platforms. Please like, comment, share, and subscribe. See you in the next lesson.